All right, just to watching Good Morning Nigeria on the network service of the NTA. To begin our conversation this morning on managing asthma patients, here is a background report put together by our correspondent Abdusalam Jibril.
For those who are not familiar with this, it is a handheld portable device that delivers medication to the lungs, commonly found in the possession of those suffering from asthma. A variety of these asthma inhalers help control asthma symptoms, prevent or treat asthma attacks. The World Health Organization (WHO) says asthma is a long-term respiratory condition affecting children and adults around the world. The condition affects the air passages of the lungs, making them narrow due to inflammation and the tightening of the muscles around the airwaves. Asthma attacks can be fatal, accounting for most asthma deaths. Available data from the WHO reveals that in 2019, an estimated 455,000 deaths were recorded as a result of asthma. The WHO further notes that bronchial asthma is a significant public health problem that commonly begins in childhood with an estimated worldwide prevalence rate of 262 million and is found in approximately 10% of children and teenagers less than 18 years of age. The condition, they note, is characterized by recurring respiratory symptoms such as coughing, wheezing, shortness of breath, and chest tightening. The symptoms varies and could fluctuate for each individual over time. According to the Nigerian Thoracic Society (NTA), about 15 million Nigerians suffer from asthma. Some medical practitioners also say about 75% of Nigerians suffering from asthma risk dying from the disease due to poor control. They claim that many patients do not use inhalers appropriately, and death occurs when they do not use appropriate inhalers in the event of an attack. They prescribe education involving patients, caregivers, and healthcare workers to help reduce frequency and severity of symptoms, since asthma is not curable but treatable. What more should be done towards the management of those suffering from asthma? This and more guests will be speaking to shortly.
Thank you, Abdusalam Jibril, there for the background reports and to discuss the issue this morning, managing asthma patients. We have in the studio Dr. Mwanta Nehi Hari Paul, Senior Registrar, Pulmonology Unit, National Hospital, Abuja. Welcome to Good Morning Nigeria.
Thank you very much, sir.
Good. Also via Zoom from Gwagwalada, we have Dr. Ako Alexandra. He is the Senior Lecturer and Honorary Consultant Pulmonologist, College of Health Sciences, University of Abuja, and University of Abuja Teaching Hospital. Dr. Ako, you are welcome to Good Morning Nigeria.
Thank you very much. My pleasure to be with you.
All right, we are being joined by doctors across the country, and now it's a pleasure to also welcome to the program Dr. Hassana Abubakar, Imam, consultant physician and pulmonologist at Aminu Kano Teaching Hospital. Of course, that connection will be made perfect in the course of the conversation. Of course, we also have joining us via Zoom from Yenagoa, Dr. Jumbol Jumbo, an associate professor, Department of Internal Medicine, Niger Delta University, and consultant pulmonologist, Niger Delta University Teaching Hospital, Bayelsa State. Dr. Jumbol Jumbo, good to have you on the program.
Thanks for having me.
Okay, thank you very much for joining us. Now let's start our conversation with Dr. Paul here in the studio. When we talk about asthma, how would you describe asthma, and what exactly is asthma attack? When you say somebody has an asthma attack, what are we talking about?
Okay, thank you very much for the question. So asthma generally is a chronic inflammatory airway disease. It affects typically the airways, and usually characterized by some factors like airway inflammation, airway hyperresponsiveness, and airway obstruction. And what is typical is how it presents. So there's variable airflow limitation, which varies in time and intensity. So when you say someone is having an attack, it means that the person is having symptoms. When they're symptoms of cough, breathlessness, chest tightness, and wheezing. So when you have symptoms, worsening symptoms like that, you say the person is having an asthmatic attack, acute asthmatic attack.
Okay, so when you notice somebody is coughing, is breathless, okay, that's an asthmatic
Having
attack.
wheezing sound.
Wheezing
Yes,
sound.
like a noisy breathing. Then there's chest tightness.
Okay.
So when you notice that the symptoms are getting worse,
Okay.
and it's not getting relief with the usual medication or inhaler, you say that person is having an attack, and it's very important that that person will seek urgent medical attention when that attack happens, because sometimes these medications or inhaler might not be able to control that attack. So the person will need to present to the hospital, to the emergency for attention.
All right, thank you, Dr. Paul. Dr. Alexander, let's get to you now. I want you to throw more light, beyond what Dr. Paul has told us about asthma, and also let us know what are the triggers. How am I, just being a normal person, not having a medical degree, how am I supposed to know that this is an asthmatic attack and this is just maybe a normal reaction to probably the weather or whatever it is? So let us have that.
Okay, thank you very much. Thank you. Dr. Paul had introduced the subject matter properly. When we talk about asthma, so when we talk about asthma attack, when the truth of the matter is that a number of people have symptoms that look like common colds, like we rightly alluded to, that may look like asthma attack, but there are other things you need to consider in order to really make diagnosis of an asthma attack. But be as it may, let me just answer the question quickly. The list of triggers, things that trigger asthma attack, is quite long. Some are inherent or internal to the individual, and some are external. Inherent factors are factors like the emotional state of the individual. Some people, when they are excited, they have an attack. Some people, when they are sad, they have an attack, mood swings, and a lot of these psychological changes predispose or precipitate asthma attacks in individual. Now, these are the internal factors. The external factors are easy for us to recognize because people usually come in contact with them. And the list is quite long too. It can be from food agents that we come in contact with, as simple as some people eat peanuts and they come down with asthma attack. Some may be prawn, seafood, prawns, crayfish. Some people come in contact with cockroach. In fact, we've had reports of people come in contact, their exposure to rats trigger asthma attacks in them. Others may be dust that carries pollen grains inside of them, and the list is quite long, really. So in most cases, individuals are encouraged to recognize some of these triggers which are available in our environment and which they recognize as triggers to their symptoms, because shortly after exposure to these triggers, asthma symptoms will start, like Dr. Paul had enumerated for us this morning. So it's important that we take note of this, and triggers form a very good and important part of management of this patient, because if you don't address the triggers, you may have an individual who keep being exposed to them and their control will not be adequate. So I'll just stop at this, and then maybe others can respond. Thank you very much.
Okay, Dr. Alexander, thank you for your contribution there. Let's come back to the studio now, where Dr. Paul. We have Dr. Alexander has told us the triggers of these asthma attack. But what are There are a number of factors, you understand, that are thought to increase the chances of developing asthma, especially in this part of the world. What are these factors?
Okay, so thank you very much. So the factors that cause these asthma attacks is multifactorial. So it can be both environmental factors and also genetic factors, because there's an interplay. When there's a genetic predisposition for someone to have asthma and is exposed to things in the environment, we call them allergens. So a reaction is triggered up and they start having symptoms. So there are other factors like in the family atopy. So if there's tendency for the group of family members to have allergic skin reaction, problems with their eyes, like what we call conjunctivitis, rhinitis, or tendencies to have any allergic problem, they are also at risk of having asthma. Then other factors like smoking is also, or even secondhand smoking is also something we should consider. Then industrial pollution are also other things. Infections in the environment, most especially viral infections during cold weather, they can also trigger or precipitate an attack of asthma. So there are lots, and you should know that asthma is a heterogeneous disease. So there are different aspects that come into the diagnosis.
Heterogeneous, how do you mean?
Okay, there is not just, I would say, okay, not one cap fits all. So what, the way patient A, they present with the asthma is different from the way B or C will present. So there are different factors that come into play. There's what we call a phenotype of asthma, meaning that there are different physical appearance or habitus that you see in a patient that characterizes that particular patient. So you see individualized care is very important when you are addressing such patients. You don't just manage everybody equally. So it's an individualized approach that you give, and also holistic approach.
All right, looks like a very complicated kind of medical condition here, since individuals would definitely present different symptoms. But let's get to Dr. Jumbo now. I want to know, how are you able to detect that someone has asthma? I mean, a child is born. At what point, you know, is the parent aware that, okay, this my child has, you know, a condition known as asthma? How are you able to detect that from birth? And then the symptoms, you know, like Dr. Paul said, they're individualistic. Now, is there a difference between that of children, that's the pediatric asthma, and the way it presents for adults?
Thank you very much. I thank my colleague for introducing the topic. Oh yes, when a child is born, sometimes a child with asthma symptoms may present with wheezes. That is noisy breathing. Noisy breathing, and in some cases, the noisy breathing may not be caused by asthma, because we have a bronchiolitis in children that could also present like that. Some of these children outgrow it, but some may develop asthma as adults, and so in some cases the asthma symptoms will continue. The symptoms, the cardinal symptoms, cough, wheezes, chest tightness, and difficulty in breathing, may not present in all patients. Some of these patients may just present with one or two of these symptoms. But the peculiarity about these symptoms is that they are episodic, meaning that they come and go sometimes without even treatment, spontaneous resolution. Unlike other conditions, because there are so many conditions that can present with wheezes and cough, even heart conditions. But in the case of asthma symptoms, they are episodic. They come and sometimes they resolve even without treatment. And they could most likely have triggers. So these are some of the peculiarities with the symptoms. Not all wheezes are symptoms of asthma, but in most cases, wheezing is a very common symptom. Cough is a common symptom, chest tightness, and difficulty in breathing. So it is quite necessary as medical practitioners and the general public to really have an idea of how these symptoms present. The episodic nature of the symptom is important. There is another common feature about these symptoms. They are worse at night. These wheezes, cough, they are worse at night for some obvious reasons. And sometimes it's associated with triggers. So those peculiarities, make the doctor or the health practitioner to know that this is likely to be asthma. Then making diagnosis of asthma, especially in children, it can be very difficult, especially when they are less than 5 years old, because the main way of making the diagnosis is spirometry. Children less than 5 years old may not be able to, have that technique to really blow a spirometry, because you have to blow it with some force to determine how the air is in the lung. So in small children, you really have to have a high index of suspicion when they present with these symptoms. Thank you.
Quickly, because you said wheezing in newborns sometimes is a sign that they're asthmatic. For a lot of mothers, we get to hear that if you drink a lot of cold water when you're pregnant, it affects. Is that a causative factor for asthma? That during pregnancy your lifestyle could affect your child coming down with asthma at birth. Just speak to us about what causes it. Why would someone be diagnosed as being asthmatic and the other person not?
Yes, okay. Thank you. Cold water is not known to be associated with wheezing in children, newborn children. I think there are some other factors during pregnancy that could contribute to development of asthma in the newborn. One of the factors is exposure to smoke. Exposure to smoke. Yes, exposure to smoke, even passive smoking. Then also use of broad spectrum antibiotics. Frequent use of broad spectrum antibiotics during the pregnancy can also, contribute to that. It's also said that vaginal delivery, when a mother delivers vaginal, there is less tendency for the child to develop bronchial asthma compared to other modes of delivery, like a cesarean section. But the intake of cold water and all that is not known to be associated with development of asthma in the newborn.
Thank you very much, Dr. Jumbo, there for the clarification. Let's come back to the studio where we still have Dr. Paul. Now, when a child is diagnosed with asthma, and how do you handle such situation?
Okay, so thank you very much. So once the diagnosis is made, and specifically using spirometry or your peak flow to monitor, that diagnosis is made. So it's important that the child is managed appropriately by a specialized team, the pediatricians and pediatric pulmonologists. So they'll be able to follow up the care, because this kind of patient, they have to be on some medications. And chiefly the medications we usually prescribe are those that will help to control the inflammation. As I said earlier, there's airway inflammation, which is the key part in the disease process. Okay. So that inflammation needs to be reduced or quelled down, because once that inflammation is up and they are exposed to allergens or things in the environment that can trigger a reaction, you see them continuously having symptoms. So the key role is to reduce the inflammation, and there are medications that can do that. Inhaled medication, inhaled corticosteroids. So they go locally to act in the airway to reduce the inflammation. So once the inflammation is reduced, the tendency of having symptoms, worsening symptoms, is less. So the over-reliance of other medication, we use salbutamol inhaler. The global initiative for asthma is telling us to downplay that use, because studies have shown that when these children or even adults use this medication or over rely on this medication, it worsens the condition. They keep on having worsening symptoms, exacerbations, and that is not good. So the key role now is to give medication containing inhaled corticosteroids and a long-acting beta blocker, which opens up the airway. So this is the recommended standard now to use this medication in the
for newborn babies.
Not newborn babies, because you can't make that diagnosis. As my senior colleague said, there are other things that can mimic asthma. Bronchiolitis, even bronchitis, different things can mimic asthma. So you cannot make that diagnosis at an early age. So from 5-6 years
that's when they can be assured that this exactly is asthma.
Asthma, you can do a spirometry test for them, and then you can follow up the treatment. You can even have an individualized plan for them. You understand? So that you teach the parents of these children how to recognize when they have worsening of symptoms in their children. Are they having cough? Are they having noisy breathing, wheezing? Do they feel breathless? Or are there limitations in their exercise tolerance or the activities? Or are they absent from school? Because asthma is one of the causes of absenteeism and presenteeism. So absenteeism, that means they can't go to school, they can't go to work, or even when they go, they can't do anything because of symptoms. They can't participate. Yes. So you follow up these patients, and you regularly check on their symptoms and check if are they having frequent nighttime symptoms, or are they awakening because of the asthma symptoms? Are they using the short-acting inhalers frequently? Because when you assess and you see that they're using it frequently, there's tendency that they will have more exacerbation or worsening of their symptoms. Even the risk of death too has been attributed to frequent use. So if you're using like up to 12 canisters in a year, you say the risk of death is very high. And if you're using up to 3 canisters, you see the risk of worsening of symptoms or exacerbation is increased. So you monitor this patient, and there's peak flow meter, which can also be used to monitor their asthma. Because when we talk about an action plan, it's just a written note that helps the patient monitor their symptoms and tell them what to do or what medications to take when they are having worsening symptoms, and when to present to the emergency, and even before presenting, what actions they can take while at home before they get to the hospital. Then, using the peak flow meter, it can also tell to predict if the symptoms will get worse. For example, if you have up to 80 to 100 of your personal best, you know that you're safe, you're in the green zone, because the action plan has like a traffic light approach in managing. So there's the green, the yellow, and the red. So the green, meaning that you are safe, you don't have any symptoms, your personal best of your peak flow meter is about 80 to 100%. Then if you're in the yellow zone, it's just telling you that it's warning you. So it's between 50 to 80% of your personal best of your peak flow meter, and you're having some symptoms. So in that yellow zone, you might need to increase the use of your medication. Your doctor will tell you, increase the use of your medication to prevent the symptoms from worsening. Then the red zone is when you're having less than 50% of your personal best, and you're having symptoms, you can't make a sentence in a breath, you're severely dyspneic, there's limitation of your activities. So in that regard, you will need to start taking your rescue medications to quickly help at least every to quickly help your breathing, and you will need to call in or go immediately to the emergency room for attention.
And when you exceed the red light, what happens?
That is emergency, so you will need to go to the hospital.
So maybe there will be a black light eventually.
We hope there is none, but that is just the warning.
All right. Thank you so much, Dr. Paul, for that explanation. Dr. Hassana Abubakar Imam, who joins us from Kano, is ready now. Dr. Hassana Abubakar Imam, I hope you've been following the conversation. So much has been said already. The foundation has been laid as regards asthma and all of that. But, you know, while I spoke to Dr. Jumbo earlier, you know, asking about the causes and, you know, especially for children, he talked about lifestyle during pregnancy, and he mentioned antibiotics, he mentioned smoking, even secondhand smoke could, you know, cause asthma for newborn babies, which I eventually diagnosed at from 5 years, like he clarified. But I want to find out, so can you develop asthma? Can you become asthmatic at a later stage in life? You know, and then what are the causes of that? And then is it true that people who live in cold regions are more susceptible, you know, to being diagnosed with asthma than those who live in hotter regions? And also, could you tell us, is it hereditary?
Good morning. Thank you for the questions. So, with regards to causes of asthma in the elderly, there's what we call risk factors. Risk factors for asthma, meaning they're not direct causes, but then there are factors that have been associated with development of the disease. So these risk factors include exposure to smoke, cigarette smoking, and this cigarette smoking not just affects the adult or an individual, but it also affects the unborn child. When the mother smokes, when she's pregnant, the child could be susceptible to developing asthma in later life. So talking about in utero factors, there's when the child is born with either low birth weight or prematurely. And then, so the natural history of asthma is that during childhood, the child could present with asthma. And at that time, it has been found that there are more boys being asthmatic than girls. So by the time they get to puberty, the asthma could remit, meaning the child could no longer be asthmatic. However, during adulthood, some individuals could have some individuals that had asthma during childhood could have asthma in adulthood as well. Then again, we have individuals that never had asthma when they were children, but then developed asthma at adulthood. And then again, in some rare instances, the elderly can also have asthma. So other factors include allergy, meaning in layman's terms that you're prone to have exaggerated response to either environmental or exposures to things like dust, fumes, smoke, and all that. Particularly if there's a so now answering your later question, if it can be inherited. So yes, there's a form of asthma, not all asthma, that is actually familial, meaning it runs in the family. And this type of asthma particularly is associated with what we call atopy, meaning familial tendency to have allergy, and it runs in the family with first most importantly, when you have your first degree relative being asthmatic, and usually it's related to other conditions like Dr. Paul mentioned, with other allergies such as allergic conjunctivitis, allergic rhinitis, and dermatitis. So other risk factors include what we call the hygiene hypothesis. So this hypothesis states that, particularly during childhood, when a child is being exposed to a clean environment. So paradoxically, clean environments, make one more prone to asthma, as opposed to, being exposed to an environment whereby, like for instance, being in a farmhouse where you have a lot of environmental exposures. So why this happens is because when the environment's clean, so now to explain this so that we understand, taking the immune system, meaning in our body we have, like, let's call them soldiers that checkmate infections and other hazardous or particles that come into the body that potentially could harm us. So when you're exposed to that, two type of, should I say, soldiers, defense cells, we have two particular type. So there's this particular type, let's call them type 1 and type 2. So when you're being exposed to such an environment where there are a lot of, environmental, say, substances, like, say, a farmhouse that has animals with their secretions, or has cockroaches or rodents. So in being in that environment, your body now switches to, like, say, brings out your soldier, let's call him type 1, the T1 soldier, to, like, defend you against all this. So doing that, as the T1 soldier comes to the forefront, the T2 soldier is relegated to the background. However, when a child is being exposed to a clean environment, the type 2 soldiers aren't brought to the forefront, meaning they're, should I say, non-active, and then the type 2 soldiers will now be the more dominant, protective cells. So, and then the type 2 soldiers particularly are, they are, involved in, inflammatory processes that, make one more susceptible to having reactions to exposure to substances that might not necessarily, like, cause any symptoms. So yes, so now going to your question about having asthma, as in asthma being prevalent in more cold regions than warm climes. Well, you see, asthma is prevalent worldwide, and the prevalence is increasing. We have had an increase within the last decade or so. So it's prevalent everywhere, cold, warm climate. So cold climate is not particularly a predisposition to asthma. However, if we're going to talk about, like, say, propensity to develop viral infection or any other infection that could predispose to triggering asthma, yes, I would say cold environment, be it in cold climes or warm climes, like us during Harmattan, yes, you have virus organisms thriving better then, and then yes, you could come down with a respiratory tract infection, which could trigger your asthma. But then particularly being in a cold region doesn't necessarily or doesn't particularly predispose you to having asthma attacks. Yes, so I think over to you in the studio. Thank you.
Giving us the clarification there, especially what you talked about, the issue of, someone living in a clean environment and also being diagnosed with asthma. I found it strange, Dr. Paul. How come? I mean, because we have been told time and time again that a clean environment is good for your health. Cleanliness is next to godliness. That's what they say. So how come that a clean environment can also lead or trigger asthmatic attack, just like she said? It's what exactly is the issue here?
No, it's just an hypothesis, as my senior colleague said.
All right.
It's just what studies have shown, and they've hypothesized that if those that are prone to various infection in childhood, say bacterial infection, viral infection, their immunity is built up. So there's less likelihood that they will have asthma compared to those who never was exposed to this infection. They would likely come down with asthma. So it doesn't mean that is a risk factor, or it's what would you staying in a dirty environment would less likely trigger. It's just an hypothesis which they discovered that those who studies have shown that those who are asthmatic, they are usually from affluent areas or clean environments than compared to those that were heavily exposed during childhood.
Okay, because of their immunities are low.
Yeah.
Okay. Okay, I see now. Can you give us a vivid breakdown of these adult onset? Okay. Before I come to you again, let's go to Dr. Ako in via Zoom. Dr. Ako, I believe you are still with us. I want you to just give us a vivid breakdown of the adult onset of asthma attacks. Can you just give us a vivid onset? Because, just like as it has been said, that some people may not have asthma maybe during birth or at a younger age, but at the older age, they begin to, see the symptoms of asthma. What exactly are the vivid onset of it?
Thank you very much. Truly, most asthmatic patients would have presented much earlier in life, either as children or in their early adulthood. But we know that there is a late presentation of asthma that occur in adults. But there seems to be a specific distribution of this group of people. Commonly, you find out that there are people who probably are engaging in one occupation or the other. Usually, it's as a result of exposure from occupational sensitizers. What do I mean by this? Some people, by virtue of their occupation, come in contact with certain sensitizers that have capacity to produce asthma. That's why you find it in that group, in the adulthood, because it's at this time that they get engaged in jobs and their vocation, and then they come like, well, example of this are like hairdressers. You have hairdressers who use a lot of these sprays and agents that they use in making hair that we know that have sensitizers inside of them. Others are like people who work in bakery. Others include people who work in cement factories and all of this. So there seems to be a distribution of this category, but commonly you find out that there is a sensitization from the work environment. That seems to describe those who present late with asthma symptoms. It means that earlier on in life, they didn't have asthma, but they already have the genetic predisposition to having asthma. So later on, when they get exposed to specific sensitizers, they come down with the typical and classic symptoms that are consistent with asthma. But like I've said, what is key for us to recognize here is that most of the adult onset asthma are really as a result of exposure to what we call like triggers, or from the work environment, or from the places where they engage in their day-to-day activity from their homes.
Dr. Alexander, thank you so much. Dr. Jumbo, you're listening all the way from Yenagoa, Bayelsa State. Initially, when you spoke about the pediatric cases, you talked about children born via cesarean section are more likely to come down with asthma. I'd like you to clarify, and does that mean we should discourage cesarean sections, if you like? I say that because these days we know that doctors think that it's easier, or if you like, prefer, or we're having increased cases of cesarean sections compared to vaginal delivery because of less complications in other areas. But now we're talking about asthma, and you have mentioned it as a trigger. That's one. Then I'd like you to talk about the misconceptions about asthma, and how we can address them.
Well, the issue of having cesarean section is categorically when a child is born through cesarean section, that child is likely to have bronchial asthma. No, but when you compare vaginal deliveries with cesarean section, you find out that those that are born through vaginal delivery has less tendency, but there has not been a serious association with occurrence of asthma in children with the cesarean section mode of delivery. Then they're talking about stereotype, what people think about asthma. There are a lot of explanations to it. Some persons attribute, asthma to a lot of things, witchcraft, so many other issues. But the real reason is that could have been likely a genetic predisposition, a family history, a strong family history of asthma is a strong predisposing condition. Then history of allergy in the family also could be a predisposing condition. So in some cases, a child may have some childhood symptoms quite early in life, very early in life. That child may not even know that he has symptoms, but when they grow up and maybe locate to a place where they are exposed to triggers, then the asthma will start managing. As my colleague earlier said, certain occupations. But some people may attribute that to a lot of things in the community. They were saying drinking of cold water, all manners of misconceptions are there. And some will say even it's a cause from the gods and all that. But the truth is that there are two main things: genetic predisposition and allergy. When they have those predisposing conditions, there are other contributing factors that have been earlier mentioned and triggers. So when somebody is exposed to those triggers and contributing factors, the person may come down, as we say, chronic disease. So the concept is, some people misconcept it. It's a chronic disease. There could be some misconception because they expect that when once it's treated once, that it's not expected to occur. But it is not, because it's a chronic condition. It's controlled. It's controlled with the various treatment models depending on the severity of the disease. And it can occur in a way that is very, very spontaneous, where if somebody will just be somewhere and exposed to certain things, and all of a sudden the person is becoming breathless. So because of the mode of presentation in some of the patients, it will be attributed to a lot of things, and there could be a lot of misconceptions. So our duties as healthcare practitioners is to disabuse the public of this misconception. Asthma is mostly a genetic condition. It's mostly a genetic condition, and that when there is a strong there is a history of allergy and women that has contributing or trigger factors, the patient may like to come with.
I think we're having some audio tech issues with, okay, I think it's a network issue with Dr. Jumbo. Anyway, thank you for that contribution there. Let's come back to the studio. Dr. Paul, you have heard that the misconception, especially generally by the people, and another misconception that I noticed or have heard, like medically, they said, you said that asthma is not curable, but it's manageable. How true is it? Because there are a lot of adverts out there. Some people saying, "Oh, look, asthma will cure it. Just take this medicinal, this herbal tablets. This, it will be gone in less than 1 month, 2 months." Is it curable? Is it a misconception? Is it true, or what exactly is?
Thank you very much. Just to add to what my senior colleague was saying, so there are various myths to asthma, and most people will see asthma as when they have symptoms, they need to take their medications, and when they don't have symptoms, they don't take their medications. But I would say that is very wrong. Asthma is not curable. It's a chronic respiratory condition. There's no cure for it. However, there are effective treatments to manage symptoms. That when you take these medications, it will be as though you don't have asthma, but doesn't mean that it's not there. It's a chronic condition. It's not curable, but it can be managed effectively, and there are medications that can do that, that can help manage this condition. So that's why the global initiative for asthma, this month, which is the month of May, we had a celebration on the 7th of May. So that celebration is to drive home what we need to do in terms of education, because for the theme this year, it said asthma education empowers. So it's to empower those that are suffering from asthma, their relatives, and the community about what to know about asthma. So the key factors here is to drive home the fact that a diagnosis needs to be made of asthma, accurate diagnosis of asthma, and also to use medications that have been shown to be effective. For example, as I said earlier, there's the inhaled corticosteroid medication, which is central in the management. So we should talk to our patients about the use of these medications, which is effective for reducing inflammation and also controlling or preventing symptoms. Then over-reliance of other relief medications like short-acting beta agonists, for example, the salbutamol inhaler, the blue inhaler, which we commonly see. So we want to downplay the over-reliance, because many studies have shown that if our patients continue using this medication, the tendency for them to have worsening symptoms or not getting controlled is high. So the whole essence is to talk to our patients so that their symptoms are controlled, and also to identify when to seek medical attention, specialist attention. When they are having worsening symptoms, they should know that this is the time to go to the doctor and not to go to the chemist shop or go to a traditional shop for cure, because some people think it's a spiritual problem, that somebody threw an attack and is seizing their breath, but it's not. It's one of the myths that
village people are discussing about.
Yes, that we need to address. because as my senior colleagues had earlier mentioned, it's a genetic problem which can also be acquired too based on their activities, occupational, can be occupational as well, but also the impact of the environment also come into play. So you see that it's multifactorial, and we need to address that.
But when you say the impact of the environment, because I could recollect a friend of mine relocated about maybe 16 years ago. When the child was here, the child was asthmatic, chronic. But the moment they got to England, for the past 16 years now, he told me that, look, my child has not gotten no attack, no sign at all. Is it environmental, which means that he's cured? That's what he was telling me. And he's a doctor, but not a medical, a vet doctor. But I believe that he's literate enough to know whether someone is cured or not.
Okay, it's not cured. The child just had a better control of the symptoms based on the fact that maybe the child was using, there's medication, availability of good inhalers, you understand, to use, and
he said he doesn't use any. I mean, since they got there, they've not used any.
Yeah, because when you're exposed to triggers or things in the environment, you have symptoms, definitely, because I said inflammation is the central theme in the occurrence of the disease process. So once you're exposed to triggers, you definitely have symptoms. So if you're not having symptoms, it's possible that there's some avoidance of triggers, or you are using your medication better. So, but it's a chronic condition, and it usually extends to adulthood. But it can be managed that you will not even have symptoms, or the symptoms will be negligible if you take your medications.
For a long time, like 10, 15 years, they will not even see the symptom at all.
It's possible. I have patients like that who have reported that they don't have symptoms. That is the last time they had an attack is years. It's possible they've been avoiding triggers, they've been using their medications, and they don't have symptoms.
All right, thank you, Dr. Paul. I'm not a doctor, but can I call you my senior colleague? Because you appear to have been referring to every other person as your senior colleague. So let's go to Dr. Alexander now. You know, so much has been said about asthma, but I would like you to talk about the impact of asthma on the mental health of the patient, and also talk about the activities, general everyday activities and quality of life of an asthmatic patient.
Thank you very much. Asthma affects individuals generally, and the impact is quite substantial. Earlier on, Dr. Paul had talked about it. Most of the patients who have asthma will probably have had asthma in their childhood. And so when you put both in terms of the economic burden and the disease burden, it's quite huge. Here you have a child who probably will not be able to attend school because he's having frequent attacks. That child is likely not going to do well in school. And that child is probably the future of the nation. But let's not forget that this same child cannot take care of himself, so he will need the parents to take care of them. The parents who in themselves will have to miss their jobs, or will have to reschedule jobs so that they can attend to their sick child. So if you're able to harness or put together the cost of it, it's quite substantial. The other part of the impact is to look at in terms of costs too. Though we have effective drugs that are quite available, but the issue is that the costs, and even when you're able to get around the costs of this medication, the other thing is that the beliefs like Dr. Jumba talked about, belief practices, and all of that. So all of this actually add up to the impact of this challenge that we're having. And you can imagine that we still have up to like roughly 500,000 deaths that do occur. And maybe we didn't say this. It's important for us to know why we're making this noise. 90% of this challenge will occur in resource-scarce environment, of which we fall into. Even though we have available treatment and all of that, but majority of the impact and challenges we have will occur in our own environment. So it's important to take note of this. Then when we look at the impact overall, because this same child that is unable to have good control is likely not going to sleep well at home. The parents are likely not going to sleep well because of the challenges of their child. They are worried about the child who is not doing well. And once people don't sleep, it affects the quality of life they live. And once people can't get to do their daily day-to-day, it affects the output and productivity from such individuals. So it's like a vicious circle. And that's why we just have to make every effort to break it. We also talk about quality of life. You get to see the fact that sometimes the families that are involved with it seems to be like a community thing. They need to raise resources and all of this. So when we look about the impact and in terms of how it affects, it cuts across. It puts a lot of burden in terms of financial costs on those who are taking care of individuals who suffer from this disease. It also affects work, like my colleague has said. It affects, it causes absenteeism, both on the part of the sufferer and on part of the caregivers. It affects the quality of sleep and all of this. So when you put all of this together, it's quite enormous. And because all of these are affected, it brings about the psychosocial disorders that is commonly associated with asthma. Asthma has to do with a lot of all of these psychosocial problems. People are anxious. They are anxious about their treatment. They're anxious, will they die? They're anxious, will they get good outcome out of their treatment? So there's a lot of anxiety from both the sufferers and the caregiver. Again, we have the opposite side of it. Some people get depressed, especially when they get to maybe not too specialized individuals who can offer them a good management of their asthma. So they get depressed from the fact that they spend so much, but they are not seeing the output from the quality of care they are getting from the asthma. And all of it has to do, like my colleague has said, about education. It has to do with education. Because once people are well educated, they're empowered, and they make all the right choices and the right decisions. They even know when things are not going well, when to seek a specialist, when to seek help from someone who can offer them correct and quality asthma care and management. Thank you very much.
Thank you very much, Dr. Alexandra, for giving us the impact of the asthma effect there. We'll take a break now. When we come back, the conversation continues. Stay with us. Well, you're welcome back. We're still talking on managing asthma patients. And we'll go to our Kano studio where we have Dr. Imam. Dr. Imam, let's talk about the issue of enlightenment now, because there is need for adequate enlightenment on the part of the caregiver and also on the care of the generality of the people and the patient as well. How do we enlighten people on management and how to handle someone that is asthmatic?
So thank you for the question. Yes, so enlightenment is key in management of any disease, be it asthma or anything. Because for the patients, if they understand their disease, they deal with the disease, they would know what to tell their doctor, what is important, what is not important. They would have a choice on the best medication, like for instance, for the asthmatics, the inhalers. They could, tell you the best, say, device that works for them, and, they'll know what should be and what shouldn't be. When they should seek help and when they shouldn't, when it's serious and when it's not. Importantly, when you educate patients about asthma being triggered by having certain triggers, we call them allergens. When you educate them about that, that is an environmental, the environment has a key role to play in their disease. You educate them about that there are allergens or triggers in the environment. You educate them about certain types of triggers that they could be susceptible to, and you educate them that the very first step in their asthma care is to be able to identify these triggers or allergens, meaning For that particular individual, because allergens or triggers could differ from patient to patient, what patient A has as triggers might not necessarily be what triggers patients B asthma. So educating them that there are certain triggers, what they are or what they could possibly be, and then telling them to avoid these triggers will go a long way, in managing their asthma. Because as I said, it's an the environment has a lot to play in, asthma. So, if I may add to what Dr. Paul said concerning the patient that, change environment from being in Nigeria to going abroad, and then the asthma symptoms abated. So what happens is that not only having to go out of the country, it's, like patients they come with symptoms, and the symptoms are not getting resolved. So what you should investigate, part of your investigation to find the cause of, their symptoms, worsening symptoms, is their environment, the particular environment they are in. What are the likely allergens or triggers that are in the environment? And you could go further to ask them, okay, so is it likely that when you say, probably if you're in a boarding house, is it likely that when you come back home from school, do you have less attacks or more attacks? Or say you travel from one state to the other, or say you go on a sleepover or something to another house, when you are in certain environment, do you have more asthma triggers, asthma attacks than others? So meaning if you do, then these certain allergies that triggers your asthma are contained in that environment. So you see, you educate patient on the asthma, particularly that it is genetic, meaning that that individual is predisposed to it. So it's inherent in you. However, if you avoid certain triggers or allergens, you will not come down with symptoms. So it's important for patients to know that. Secondly, you also educate them on the importance of their asthma medication and the technique of using their inhalers. So as when talking to patients, as I tell them, your asthma relief is as good as your inhaler technique. So if it's good, you'll be able to deliver the required dose to where the medication will act to open your airway. So that is to, and then again to educate them that there are certain things that, when they experience, particularly when they have an asthma attack and then they've used their inhalers for like say 3 times in 30 minutes and it's still not getting better, they should know that they should be able to present themselves to the hospital and what to expect in the hospital. And then again, as Dr. Paul has earlier mentioned, they should be educated and given an action plan right before, when they are stable, before symptoms occur, so that they'll be able to know at each step of, their disease or exacerbation or attack what they can do. So now this is educating the patient. Then it's also important to educate or to make healthcare professionals aware, to increase awareness of asthma, particularly when it comes to management. I don't know if it's obtainable elsewhere, but then locally where I practice, there's a misconception that when you use your inhaler, the more you use your inhaler, the worse your asthma gets. And then, they tell you that, when patients tell you this, then that means they could meet any other health professional. So every health professional should be, made aware of, patients' misconceptions. To start with, what asthma is, the myths that patients have about asthma, so that you'll be armed to be able to educate your patient effectively, to be able to, do away with that myth. So again, with regards to awareness, stakeholders too need to be aware about asthma. There are policy makers, and other stakeholders, the government, and all, that need to be aware of asthma, its impact on, the societal health, its impact on, its economic burden and all that. And particularly recently that, we've had, well, a shortage of inhalers, due to, some reasons. It's particularly important that policymakers, stakeholders are being aware about the importance of asthma and importance of asthma medication. Breath is life. Breathing is everything. Asthmatics, they have problem of breathing. So they depend on their medication. They cannot afford to go without their medication. So yes, awareness is key in management of asthma for the patient, for the healthcare givers, and for policymakers. So thank you.
Very detailed there, and straight to the point. Dr. Jumbo, I'd like you to pick up from where she dropped off. Talking about government, playing a role. Is the medication for asthmatic patients covered in the NHIA? And then other doctors have spoken about how it is a burden financially. Give us figures, what it will take, in terms of monetary value to manage an asthmatic patient. Then, Dr. Imam talked about what an asthmatic patient can do, knowing triggers and all of that. But just in case there's an attack, what can bystanders do? Because sometimes you see somebody comes down with an attack and people are just there looking, running around, trying to pour water and all that. What should bystanders, onlookers do when someone is down with an attack?
Thank you. You want to talk about the average cost of treatment of asthma? Okay, thank you very much. Recently, I'm even carrying out a study on the cost of treatments and how the cost of the drugs are affecting the control of bronchial asthma. Recently, because of the economic situation in the country, a lot of these medications, especially the controller medications, because there are two sets of inhaler. One is a reliever, the one that just open up the airways, the breathing pipe, when it's narrowed because of the ongoing inflammation. That is the reliever. That's the one that most people, move about with. But the controller medication takes care of the inflammation itself, so that the narrowing of the airways will not occur. Recently, because of the economic situation, prices of these skyrocketed, extent that most patients could not even afford the treatment. And most when the patient presents.
We're having network issues, with that connection there with Dr. Jumbo. But I'd like Dr. Alexander to respond to my questions. I'm sure you got my questions. I'd like you to give us a quick answer. Dr. Alexander.
From where Dr. Jumbo was what he was trying to allude to. So we have some of these big pharma companies that, because of the economic challenges, had to move out of the country. Unfortunately, we weren't aware as an association much earlier. So let me give you an average cost. An average cost of a reliever inhaler would have gone for like maybe 5,000, which should last that patient for roughly like 3 to 4 weeks. That price had doubled up The same medication will come if you're able to get it around, maybe in the range of between 50, 60,000. It went up, it dropped a little and so on. So you can see there is a geometric increase in terms of the cost of this medication. Unfortunately, inhaled medications are not medications that a lot of these pharma companies put in their money into. So there are a few options for us really to work with, even as a nation. And these are the few options that we had challenges. A number of them had to do a lot of relocation for logistic issues and so on. So when you put together on an average, if you ask me, someone will have to spend up to like between 30 to 50,000. If we go by the way the market forces right now to get some form of controller medication or the other. Of course, if you're able to work out that mathematics, and if you put vis-a-vis the average income of an individual who has to manage this, it's quite really significant and substantial. There seems to be another group that is even working on this right now. NTS have been looking at it closely to look at what will be the impact of some of these pharma companies on management of asthma, like Dr. Jumbo have talked about really. There's a direct relationship. When the medications are not accessible and affordable, asthma control also will be inadequate. That's just the truth. So we must, while we work on the education part, because we can give all of the education, but we still need to push those policymakers and so on to help us out by making sure that these drugs are available and they are drugs that we can really access. Thank you very much.
Dr. Alexander, I'd like you to respond to the part of what onlookers, bystanders can do. You know, should they take pictures, you know, pour water, give milk, or crowd the person? What should they do when someone is having an attack?
Well, sadly, no. Those are practices that onlookers, we discourage that. The truth of the matter is that while we keep emphasizing that asthma education empowers, Dr. Wanta had told us earlier on the fact that the expectation is that no asthmatic patient should actually present even in the community because they're able to manage their own asthma control. And even for the uneducated, we have means of them on the managing and assessing severity of their asthma symptoms even at home. And so when they start seeing red flags, those are times that they should report back to the healthcare practitioner who will offer them a more proper advice how to do this. But be it as it may, because sometimes in the community still, we still have some of these things. The best will be as much as possible because we encourage asthmatics to carry along their reliever medication. Let's not forget that it's a chronic illness. As far as we're concerned, asthma is not different from people who have diabetes, hypertension. In fact, it's a disease that runs throughout the life of the person. And this is the message we're trying to say because people underestimate this condition. They underestimate the severity of their symptoms. And so most times you find out that the death that occurs as a result of this or costly assumption that they make as a result of their ailment. So we still want to push further that truly in the community, there's no place for administration of or pouring of cold water, milk, and it won't solve any problem at all. What these patients need at the time they're having an attack is to use their reliever medication, and which we always encourage as part of their own asthma education that please move around with this reliever medication. You may be stable, but once in a while, you may have a breakthrough attack. And these are times that you can quickly use your reliever medication and report back to the hospital. So I want to encourage the general public, please, we're begging you. There's no place for all of these practices. Just get the person to the closest health facility if he is not carrying his or her own reliever medication with him.
Dr. Alexander, for that advice there that they should just take the patients to the nearest hospital for treatment. Yeah, Dr. Paul, let's come back to you now. Is there any current research going on, at least, to find a cure for this asthma? Is there any development going on? Maybe, I mean, just like, employing technology, that using technology to solve so many problems. Is there any hope in the horizon that there can be light at the end of the tunnel for the cure, permanent cure for asthma?
Okay, so thank you very much. As it stands now, there's no cure. But however, with technology, we've been able to use it to manage the disease. So newer technology with telemedicine, and so we can monitor our patients. They are now smart inhalers that that have audio-visual components in the inhaler. So the doctor remotely can look at or can see the patient taking the medications. Even peak flow meters are now become digitalized. So when you are using your peak flow meter to monitor your control, it can be recorded and be sent remotely to your doctor. So that's one of the advances technology has brought. So just to add on to what my senior colleagues were saying, there are medications, inhalers, which are smart. That means you can use a single inhaler for both control and relief of your symptoms. So you don't need to have too many inhalers in your pocket. Just one single inhaler would serve as a quick relief for your symptom, and will also control and maintain your symptoms. So it's very important. So when they come into our clinics, this is what we preach to them, our patients, that we preach about the inhaler technique, correct use of the inhaler, because most people, the reason why they are not achieving control of their symptoms is because they're not using the inhaler appropriately.
Yeah, okay, so how do you advise?
Yeah, when they come to us, we would advise them.
Unfortunately, we don't have any sample here.
Yeah, so but when our patients come to us, we usually at every visit reinforce their inhaler technique and ensure that they are using it appropriately and they are getting the control. So, but we can also, there are other tests that we can also use to check, is this asthma well controlled or not well controlled? So we can ask them some set of questions. So are they having symptoms frequently? Like maybe they're having twice weekly symptoms, or are they using their the blue inhalers more frequently, like twice weekly, or are they having limitation in their activities? We can also use that to check for symptoms. So when we ask them these questions, we will now know, okay, is this asthma controlled or not well controlled? Then we can tailor a plan for them. We can have the action plan, which will tell, okay, when you check your peak flow meter and you're having this, okay, this is controlled. That means you're having up to 80 to 100% of your personal best is 80 to 100 of your peak flow. We'll say, okay, you're controlled. Or you're having, if it's between 50 to 80, you're in the yellow zone, you say, okay, it's a warning sign. So let's step up your medication. Let's increase it a bit and adjust. Then also the red zone, when it's less than 50, okay, you will need to see us in the emergency and let's see how we can help you. So when we see them in the clinic, there is a pattern, there's a circle of management that we would follow to assess. First of all, you want to assess, is the diagnosis properly made? Was it made in the first place? You want to check for comorbid conditions. You want to check for things that you can adjust or risk factors.
Comorbid condition, what's that?
Okay, for example, obese individuals, okay, those with other chronic conditions, then those who are smoking, those who have maybe reflux disease. So those are other conditions that can coexist with asthma. So you want to ensure that these conditions are well managed so that they don't have exacerbation. Then you want to adjust their medications. So you might want to take it up a bit, or you want to bring it down if the control is good. Then also you talk about review. You want to review, you want to check the symptoms, you want to check the exacerbations or other aspects in the care. So this is just a plan to see that the patient, the whole essence is to ensure that there's a control of their symptoms and their exercise tolerance is better. That's all
right. Thank you so much, Dr. Paul. Let's quickly hear the final words on the program from Dr. Imam as we round off the conversation. Your final thoughts, quickly, in 30 seconds.
So yes, asthma is a serious disease because globally it causes about 450,000 deaths per year. So as I said, breath is life, and asthma is something that should be taken seriously. We should have awareness about it, and yes, particularly the awareness we have the World Asthma Day, which usually is being marked on the second Tuesday of May. So yes, we could have a lot of advocacies, we could have a lot of outreaches and all that to mark asthma, to help our patients, to make policymakers and stakeholders aware. So asthma is breath is life, so we need to tackle and manage asthma well.
Live, find way to end the conversation, and being educated by 4 doctors on the show this morning. I think I can say that you're my senior colleagues for today with this kind of education. Anyways, thank you so much, Dr. Nwata Nehikari Paul, Senior Registrar, Pulmonology Unit, National Hospital Abuja. Many thanks for joining us. Of course, Dr. Ako Alexander, Senior Lecturer and Honorary Consultant Pulmonologist, College of Health Sciences, University of Abuja and University of Abuja Teaching Hospital. Thank you so much for being a part of the conversation. Dr. Hassana Abubakar Imam, consultant physician and pulmonologist from Aminu Kano Teaching Hospital. We do sincerely appreciate you for being a part of the conversation. And of course, Dr. Jumbo Jumbo, associate professor, Department of Internal Medicine, Niger Delta University, and consultant pulmonologist, Niger Delta University Teaching Hospital, Bayelsa State. It was an honor to have you. Thank you so much, doctors. So that's it on Good Morning Nigeria this Tuesday. I'm Henry John.
And I'm Ademola Adio. Thanks for joining us. Do have a wonderful day.